Welcome everyone to today's session of the Blum Survivorship Innovations in Cancer Screening, Multi-Cancer Early Detection led by Dr. O'Donnell. This program is hosted by the Blum Resource Center. Over at the Blum, we are grateful to the survivorship team for this continued partnership. The recording of this session will be posted on our Blum YouTube playlist and our Blum Digital Resource Center. For those of you watching live, if you have any questions related to today's session, please feel free to utilize the chat or Q&A feature throughout the session. Your questions in the chat will be used to moderate the Q&A at the end. If you have any other questions or would like more information about resources and programs offered through the Blum, please visit our website at www.dana-farber.org/resource-center or email us at blum_center@dfci.harvard.edu. Thank you all for joining us. I will now pass the workshop over to Dr. O'Donnell.
Thank you very much, and it's wonderful to be here this afternoon. I'm going to be talking to you about Dana-Farber's new department, the Centers for Early Detection and Interception of Cancer. Next slide. So, as many of you are familiar, cancer remains a leading cause of death worldwide. It is the first or second leading cause of cancer death in over 50% of countries. About 1 in 9 and 1 in 12 women are expected to die from cancer, and that global burden is only expected to increase over the coming years. Next slide. So what can we do to change the paradigm? I believe, and we have a really exciting commitment here at Dana-Farber to really focus on early detection and interception of cancer, leveraging what we know about finding disease early, which is that if we find cancer at its earliest stages, either in precancerous stages, some cancers do have precancerous conditions, or when it's still localized, that is when there is our greatest opportunity to cure cancer. What you see before you are the 5-year survivals of a variety of different cancers. And what the red box highlights is that survival and outcomes are best when we find cancers at their earliest stages. Next slide. And so Dana-Farber has done a remarkable job in contributing to drug development and cancer therapies. In fact, in the last 5 years, more than 50% of FDA-approved cancer drugs in the United States were developed in part with the Dana-Farber Cancer Institute. And while this is a very exciting statistic, imagine if we took the same research platform and the same resources that have made us so successful in developing drugs that treat cancer. What if we took that same paradigm, but applied it to trying to find and intercept cancer? Next slide. And so what we're really focused on doing at the Centers for Early Detection and Interception, or CEDI, as we refer to it, is disrupting the current model, where so much of our research is focused on cancer therapeutics, and we will continue to do that. But taking that same initiative and also applying it to identifying and treating potentially premalignant conditions. We know that premalignant conditions, what are some examples of that? Barrett's esophagus that can lead to esophageal cancer, monoclonal gammopathy of undetermined significance that can lead to multiple myeloma. If we have premalignant conditions, if we focus both on the basic science and understanding the biology of evolution, and also doing clinical trials using our cancer drugs to potentially intercept those premalignant conditions, can we prevent patients from ever having those active cancers? In addition, I've mentioned that we focus very often on treatments for late-stage cancers, but again, looking at those same treatments in earlier stage and these precursors, we're using that same translational research approach to work on trying to identify cancers early. And so this idea of early detection and interception is really trying to change the experience that we are going through to see if we can augment the current cancer model. And so Dana-Farber, through the launch of the Centers for Early Detection and Interception, has really expanded the mission. At the top of the pyramid are cancer patients, and that's how it will always remain. But when we think about who else might benefit from the type of research and work that we're doing, high-risk individuals. So who are high-risk individuals are really an opportunity and a group where we think we can potentially affect the outcomes of cancer. So people who have hereditary risk factors, For example, people with germline mutations like BRCA mutations or Lynch syndrome. People who have exposures, we know that smoking is a leading cause of cancer, but there are other carcinogens too. People who've been treated for cancer through certain types of chemotherapy may also be at higher risk. I've mentioned precursor conditions, and then we're also focusing, you see MSED positive, which I'm going to talk to about blood tests that can help screen for cancer. Next slide. And so what does it look like? What is the patient journey as we think about a new model for preventive and interception in cancer? And so when patients call in who may be at high risk, is there a front door that will really do a holistic assessment of patients and identify what patients might benefit from which different programs that we have? Some of the programs that we offer at Dana-Farber have already been in existence for a long time, like genetics and prevention, but then we have other new clinical programs that are expanding in this space. So anybody who calls in to SETI, this new program, will be asked a couple different questions about hereditary risk factors. Anybody who has a strong family history or risk factors suggestive of potential inherited condition will be offered the opportunity to meet with our genetics counselors. And then our nurse navigators will help patients understand where there may be risk and what different disease groups might be appropriate. What you see in the wheel before you in the lighter blue are the blood cancer precursor conditions for which we now have clinics. At the bottom, we see our white genetics clinics, which are longstanding in existence. And then on the right, in the more orange color, are the new early detection and interception programs that Dana-Farber offers. Next slide. And so what does a patient level journey look like? Risk assessment is the starting point, as I just mentioned. Do patients need to have an assessment with a genetics counselor to determine whether or not they need testing to see if there are any inherited risk factors? The next phase is novel screening. That's something that I'm focused on, and I'll talk about in some of the upcoming slides. What are the types of techniques that we're studying to understand how we can find cancers earlier, and whether those might be appropriate for patients who are interested in participating in clinical trials? And then interception. If someone has a pre-malignant condition, what is working with our disease-specific experts to determine if there are clinical trials for the exploration of intercepting pre-malignant conditions before they have the opportunity to become a cancer, but doing this all under one roof. So comprehensive care, where each of your physicians is talking to the other physician and working as a team with a shared mission of really building the field of early detection and interception. Next slide. And so how do we get to a place where we have the types of resources that we've cultivated through our work in drug development? So Dana-Farber is renowned for its scientific discovery and technology. We have so many basic scientists working on understanding fundamental disease biology and thinking about how we can then introduce targeted therapies that can address cancers, and then bringing that into clinical trials to study these drugs in patients who have these cancers so that we can hopefully achieve FDA approval for novel therapies that are going to change and transform and hopefully improve cancer care. Next slide. And so I lead our Center for Multi-Cancer Early Detection. I'm going to talk about this new field within medicine. Next slide. So as I mentioned, we know that survival rates improve when cancer is found early. Using the example of colorectal cancer, if we find cancer before it's spread at stages 1 and 2, the overall survival is about 91%. If it is more advanced, where it's spread to other places in the body, the prognosis goes down significantly. Next slide. So how do we start to think about finding cancer when it's still curable? Cancer screening is what we use to find cancers. However, right now, there are only 4 cancers in the United States for which cancer screening is recommended: breast cancer, colorectal cancer, cervical cancer, and lung cancer in smokers. In addition to not having screening tests for the many types of cancers that exist, we know that even when there is screening, the adherence is suboptimal, ranging from 4 to 71% in colorectal cancer. And why is this? There are a number of factors: inconveniences, distance. If someone lives in a rural community, doesn't have access to some of the types of screening tests that require procedures like colonoscopy. There are challenges across racial and ethnic minorities with access and income, particularly globally can influence access to cancer screening. Next slide. So as I mentioned, the current cancer screening guidelines recommend screening for 4 cancers. For lung cancer, it's for people who are 50 years old and meet the high-risk criteria from smoking. And the recommended test is a low-dose CT scan of the chest. For breast cancer, mammography. For colorectal cancer, there are a number of different types of tests that have recommendation. The gold standard is for colonoscopy. And finally, for cervical cancer, Pap smear and HPV testing is recommended. It used to be that PSA was recommended for men, but due to some very large studies that read out, there was some overdiagnosis and overtreatment. So recommendations for cancer screening for prostate cancer are a discussion to be had with your primary care physician and are intended to include discussions of personalized risk, including family history. Next slide. So why is it that cancer screening is challenging? For some people, it's poor knowledge of the risk and values of screening, not knowing what is recommended for them or at what age. Sometimes providers are busy. If people aren't seeing their primary care physicians on a regular basis, they may not make the recommendations for patients or may not make risk-adjusted recommendations specifically for patients who have strong family histories. People sometimes fear the discomfort of procedures. Mammograms are not particularly comfortable. Colonoscopies are a 2-day procedure, first with the bowel prep and then needing a ride if you're going to have sedation to have a colonoscopy. These can be challenging. Sometimes people worry about getting a positive result and what that will mean and are afraid to have their screening. And also, if someone feels well, they're more likely to cancel or deprioritize their cancel screening. There are a number of socioeconomic factors that can impact access to screening, such as lack of transportation, the cost. So it's not just the cost of having a screening test, but the opportunity cost of not going to work for 2 days if you're doing a bowel prep or going in for a colonoscopy. Discrimination, low literacy, or language barriers can also be a factor. Next slide. But there's an opportunity here. So if only 4 cancers have screening tests, what we know is that about 70%, just north of 70% of cancers do not have screening tests currently. So there's a great opportunity to think about this space and think about how we can improve outcomes by focusing on the 70% of cancers that do not have current screening tests. Next slide. And so again, we show another example of ovarian and pancreatic cancers where the minority, less than 20%, in fact, pancreatic cancer, it's about 10%, are found when they are localized. The vast majority only present when they develop symptoms. And so that is beyond the point of cure. So how do we focus particularly on cancers like pancreatic cancer and ovarian cancer and alternative types of screening tests that may help us find it when we know we can still cure these diseases? Next slide. And so one of the challenges of trying to screen for multiple cancers is that some cancers are less rare. Breast cancer and colorectal cancer are common cancers, and therefore the number of people who one has to screen is lower to find a cancer. And the number of tests that a primary care doctor can do is limited in the sense that there are hundreds of types of cancers. We can't possibly screen for every variant of every type of cancer. And so this idea that we can do multi-cancer early detection, aggregating or putting together less common cancers so that we can find multiple things in one cancer increases the number the decreases the number needed to screen to find actual cancers. And so one of the ways in which we're trying to expand screening is to aggregate less common cancers into single tests. Next slide. And so there have been advances in liquid biomarkers or blood biomarkers and frankly, a variety of other biomarkers as well that have opened up a new field of trying to screen for cancer through looking at blood, looking at urine, and even looking at people's breath, some of the organic compounds that come out of people's breath to find signatures of cancer. And so one of the areas at Dana-Farber, the one that I'm most active in, is our multi-cancer early detection program. And we specifically look at blood tests, of which there are a number of evolving strategies for looking within someone's blood for DNA suggestive of cancer. So 20 years ago was about when we first sequenced the human genome, and we now know what normal genes look like. By the same measure, we've been able to sequence cancer genomes, and we've started to know what abnormal DNA looks like. And so it's given us the ability to look within the blood and find abnormal versus normal DNA and start to build tests that can help to screen for some of these cancers that don't have current screening tests. Next slide. And so why is multi-cancer early detection exciting? Well, I'm excited about it because I think a simple blood draw, if we can get to the place where a couple tubes of blood, which is acceptable to most people, can look for multiple types of cancers, that's something doable. That's something doable for someone here in Boston. That's something doable for someone in a rural area of America. So I like the idea that this might be uniformly accessible to patients. I like the idea that we can aggregate and screen for multiple cancers simultaneously. In addition, we may be able to find cancers earlier before they develop symptoms and are harder to treat. And again, it may address many of the issues that we have with disparities in access to cancer screening. So there are a lot of factors that make this novel area of multi-cancer early detection very exciting. Next slide. Right now, there's a lot of science going on in this area, and we here in Boston are so fortunate to live among so many universities, so many amazing hospitals and research institutes. And so there are a number of different technologies. It's not only that we can now look for DNA, but it's also that we can do it rapidly and at lower cost than what we were able to do even 5 years ago. And so it opens up the opportunity to use different techniques in these tests so that we might be able to rapidly and less expensively find more cancers. And so there are a number of different scientific methods that are being used. And ultimately, I think it will be a combination of methods that will increase the sensitivity or the ability of these tests to pick up early signs of cancer. Next slide. Right now, it is said that there are over 100 companies entering this space. This is not by any means an endorsement. It's just to give you kind of the sense of the types of interest that are in the multi-cancer early detection space now. A lot of different companies, and what you'll notice is they're using different technologies, and these, no one knows what the winner is going to be yet. This is why this is important research at this point. And you can see that the targets vary. Some of the companies go after, some of the more common cancers, where others are really trying to do a broad range and include not only solid tumors, but also blood cancers as well. Next slide. And so one of the important things in medicine, as maybe some people on this call know, is really doing the research to study the efficacy of anything we introduce into our patients and also the safety. And so just like any cancer treatments, we're equally sensitive to the importance of introducing tests into patient populations. And so to date, there have been two studies, two clinical trials, so prospective in patients, of two different types of multi-cancer early detection tests, the DETECT-A study and the PATHFINDER study. And Dana-Farber was involved and led the PATHFINDER study, which has helped to move forward one of the MCED tests that is now commercially available. Next slide. And so what does research in this space look like? So the PATHFINDER study was an assessment of the GRAIL Gallery test, what is now that, in patients, where patients, to be included in the study, you had to be over the age of 50. And there were two cohorts. There were age 50 and no other risk factors, and then age 50 and risk factors, like a smoking history, a history of cancer, greater than 3 years out, or having a germline genetic mutation. And patients all received the same test and they were given the results. These are screening tests. So when they give a result that's positive or negative, it's not a diagnosis of cancer. It's a test that says there's reason to believe you need a further evaluation for cancer, but we'll go into that some more when the next slide comes up. And so when you think about the use of these, cancer, even though it is over a lifetime, the risk is significant, and annual risk is still pretty low. And so in this study, where over 6,000 patients were tested, only 92 people had a positive screening result. And most of those people, so about 1.5% of the people screened, were in that high risk population versus 1.2% in the non-high risk. Next slide. And so what was interesting, these are tests, it's very important to understand, are not meant to replace the standard screening tests that have been approved. They're meant to complement and augment. So we want patients always to continue to do recommended screening, as we've discussed. But what we're really trying to ascertain is, can we increase the number of cancers and find them earlier by additional types of screening methods? And so as I mentioned, not everybody who has a positive test actually has cancer. These are screening tests. So if anybody's had a mammogram before, sometimes we see abnormalities when we have a mammogram that require an ultrasound or further diagnostic workup. And so that's the way to think about these tests, is that they're screening tests and they may require an additional workup. So of the patients who had a positive signal, 35 of them had a cancer diagnosis. 24 of the cancers were found in patients who were at higher risk and 11 in the non-elevated risk. About half of these patients, though, still had stage 1 or stage 2 cancers. And that's really what we're trying to get at. Can we find cancers stage 1 and stage 2 where we can intervene and cure? 71% of the cancers that were found did not have existing screening tests. So there again, trying to find cancers that would not otherwise be found. Next slide. And so at our clinic, at my clinic, where we see patients, the test, there's only one commercially available test. That's the one that was used in the Pathfinder study, the Gallery test. And people can have that through their primary care doctor. They can get that directly through Grail. It's a clinically approved test, but it is not an FDA approved test. And so much of what we do here is ongoing research to understand whether these drugs should be approved and recommended in the general population. However, if people have had MCED tests, which does occur, they purchase them or they have them through their company will sponsor cancer screening. I see those patients, about 1% of those patients, as I mentioned, will have a positive test. And then about 50% or so or fewer will have a cancer diagnosis, refer those patients directly to the appropriate clinic at Dana-Farber. But if you have a positive test and no cancer is found, there's an important responsibility to follow patients like that. We want to make sure that there is not something that is at a very early stage such that it could be picked up subsequently. So I will continue to follow those patients who have positive screening tests for whom cancer is not detected initially. Next slide. And so a clinic like this is similar to what I've described. Patients, when they call in, are offered genetics counseling if that's appropriate. And most patients who have had a positive test will require imaging. About almost 100% will either need a CT scan or an MRI. And then we often do blood tests. And if something abnormal is found, it may require a biopsy. As I mentioned, if someone has a positive test but a workup is negative, we follow those patients in an ongoing fashion. Next slide. And so I'll tell you a little bit about what we've learned so far, because I think it's been really interesting. So thus far, we've seen 14 patients who had positive tests done elsewhere who've come to our clinic. Actually, 11 out of the 14 have had cancer, and 3 out of the 14 were false positives. 55% of the cancers were solid tumor malignancies, and 5 of them, 45%, were blood cancers. 91% of the cancers found do not have current screening recommendations, and 55% were at stage 1 and stage 2. And even of some of the stage 3 and stage 4 cancers, because they were lymphomas, those are still curable as well. If someone has a false positive test, there's a free retest. And so all of the 3 false positives had the retest at least 3-month interval and were negative. And that's a very important thing of being able to offer a follow-up test to help to verify or adjudicate that initial test. This test gives a signal of origin. So if you get a positive signal, it suggests what organ might be affected. It's relatively accurate, 91%. And when patients have had positive tests, we have not encountered any issues with getting insurance companies to help provide for the diagnostic workups. Next slide. And so, as I mentioned, this is really an exciting, evolving field. I focus primarily or heavily on research around these tests. Right now, if someone's listening and eligible, we have a screening test for patients who are high risk, either if you have a germline mutation or if you have a strong family history sufficient to warrant germline testing. We're offering the Grail Gallery test for free as part of a study to understand if that's can increase the ability to screen for cancers in patients who are at highest risk. We also have a $5 million grant from the Department of Defense where we'll be studying multi-cancer early detection testing in 1,500 veterans. We also looked at the use of this through Point32 Health. which is part of Harvard Pilgrim. We were able to offer our employees this screening and understand what it looks like to implement this on a personal level. In addition, we're not just focused on multi-cancer early detection, we're also looking at the use of AI and trying to think of alternative ways that we can integrate all that's going on in technology to help identify patients who might be at risk. So we're working with Google. We have a grant through Google Takeout in patients who have lung cancer to see if we can retrospectively look back in their search histories prior to their diagnosis to see if there is common language for people who have lung cancer that they may be searching in their search engine that could then trigger an awareness that there might be a lung cancer diagnosis present. Next slide. And so just to tell people a little bit more about the INFORM study, this is our high-risk study, and we're trying to identify the types and number of cancers that we can find in patients who are at high risk using multi-cancer early detection testing. Next slide. And so here are the eligibility over the age of 35 with a germline mutation such as BRCA mutation or Lynch syndrome. If someone has Li-Fraumeni, the eligibility age is 22. And then individuals who are over the age of 45 and have a strong family history. It's not just any family history. There are specific types of cancer that are more commonly associated with being inheritable. So our team screens for who might be eligible if you have questions about your own eligibility. Next slide. And again, similar to our prior study, it's a blood draw. We give you back the results. If there's a positive test, then I would conduct the screening workup to understand if there's a true cancer there. If the screening test is negative, then we return those results accordingly. It does not obviate or change the need to continue with normal cancer screening. Next slide. In addition to the work that we're doing in multi-cancer early detection, we've also launched several new clinical programs. I'll begin with the solid tumor programs. Next slide. So how do we start to create data and understand patients at risk? So on a fundamental level, anybody who's been to Dana-Farber, you often get asked to participate in clinical trials. A lot of these clinical trials are just information gathering. Sometimes we'll pair it with blood that we store so that we start to amass enough data that we can start to learn and draw conclusions about people at risk. And so that's what the InADVANCE study is. It's a study that's really trying to ask a bunch of information from patients, things like smoking history, dietary history, in addition to cancer risk factors, so we can start to learn what might benefit or change people's risk from cancer. Next slide. The InADVANCE study is something anybody can have access to. It's free. There's a web page here that I've demonstrated where you can sign up. We sometimes do mailings that let people know about ongoing studies. And more so than anything, we're really just trying to collect information about people and cancer risk so that we can learn and start to build better clinical trials to support patients. Next slide. And so this is the different programs that are within InADVANCE in which you can see. And if you could just click one more forward, please. These are the different programs within SETI now. And it's really been something that's exciting where if you build it, they will come. And so we started one by one with MSED and with gynecology. And I'll talk about that in GI. And, now we're adding a dermatologic group, a lung nodule screening group. And so it's really exciting to see, and you can see all the doctors who've gotten involved. And so really what we're doing is asking specialists. So I'm a blood cancer specialist, colleagues who are GI specialists who've been practicing in a disease to leverage that knowledge and then take it to the precursor conditions and use all of the training that we have to do clinical trials, but apply it to this early detection and interception space. Next slide. And so one of our brand new clinics is our Centers for Early Detection and Interception of GI tumors, in particular, patients who have IPMNs or Barrett's esophagus or neuroendocrine tumors. These are not yet cancers, but have a risk of cancer, can be followed within our clinic and see a specialist, a gastroenterologist. You see Dr. Rodriguez on the left, and Marjorie Mardo is the PA mid-level provider who will follow patients over time. And as clinical trials come up, may offer those to different patients who are at highest risk. Next slide. We also have a high-risk gynecologic tumor clinic. Some patients who have genetic risk, like Lynch syndrome or BRCA mutations, need specialized screening for their risk of gynecologic malignancies. And so we now have a team that specializes in offering our patients those resources as well. Next slide. And now I'm going to talk about our programs within the blood cancers or hematologic malignancies. Next slide. And so there are some main classes of blood cancer: myeloma, multiple myeloma, which is my specialty, lymphoma, and leukemia. And many of these blood cancers have precursor conditions. So I see multiple myeloma, that is a cancer of the blood, but MGUS, or monoclonal gammopathy of undetermined significance, and smoldering myeloma are precursor conditions that can precede the development of cancer. And so we focus a lot of our research on this space, trying to understand these precancers, and specifically, are there changes in the cells that make them activate into a real cancer? Can we identify and prevent that? And then can we use our drugs that we treat multiple myeloma in for shorter durations in a certain subset of the highest risk patients to see if we can prevent or push out the evolution of that cancer? And so that was the model. That program has actually been here for 8 years. And now similar programs have now evolved in the other blood cancer types. Specifically in leukemia, we now have a CHIP clinic, a clonal hematopoiesis, of indeterminate potential clinic. And these are really exciting, novel clinics that are really helping the fields of the blood cancers. Next slide. And so what is the type of research that we're doing in blood cancers? So we have a number of trials for early screening. So the PROMISE study, for example, we recognize that in multiple myeloma, people who are have strong family histories or are African American are at higher risk of developing myeloma. So we have a screening study, free screening for individuals that may be at higher risk. And then how do we define risk? You know, if someone is asymptomatic and does not have cancer, we don't want to introduce toxic therapies. So how do we get better at studying that biology and understanding who are the people who are at true highest risk? So it's a combination of basic science, but also epidemiology, bringing in that information from protocols like InAdvance and other banking protocols to try and pair the clinical experience, the evolution of disease, with information about that patient that can give us clues about how we can identify people who might be at risk so we can prevent that from happening. And then last, just interception. How do we use, and I'm going to talk to on the next slide, some of the different types of trials that we have, some of our best therapies for myeloma. How do we introduce those in a safe way and in the right way for patients who might be at highest risk? Next slide. And so for high-risk smoldering myeloma, this is kind of gives you a sense of the breadth of the types of therapies we are exploring in precursor disease. There's work in vaccines and in immunotherapy, seeing if we can modify the immune system to target the bad cells and eradicate them before they cause symptomatic disease. There's targeted combinations, so using drugs that we already use, we use combination therapy for treating myeloma, but using it early and for a discrete amount of time to prevent disease evolution. But then for people even before that, so if people have the lowest risk disease, but still are worried about how can we introduce lifestyle things or mild therapies, you know, whether it be weight loss, intermittent fasting, but study those. The gut microbiome is of particular interest recently. We have 2 different trials going on there. So how can we help people who don't yet have cancer, who may not want to do medicines, think about lifestyle considerations using evidence to try and help learn about what one might do to prevent their risk of developing a specific cancer. Next slide. This is our team. As I mentioned, at the heart of the patient experience is really that comprehensive care. And so we've been so fortunate to really build a team of disease center champions. So within each of the specific malignancies, people who are really interested in early detection, interception of that cancer to work together with this shared goal. Next slide. If you're interested in our program, we have a website, the Centers for Early Detection and Interception. We welcome any of your questions and happy to try and assist anybody who feels they might benefit from our new programs. Next slide. And I'd like to end with this slide. So the light bulb was not the result of incremental improvement of the candle. I believe if we want to cure more cancers, then we really have to change our approach and transition some of our effort to really focusing on this early detection and interception piece. Next slide. And thank you very much. This is our team. There are so many people who are contributing to try and bring these resources to our patients at Dana-Farber. Take any questions.
Thank you so much, Dr. O'Donnell, for that great presentation. I certainly learned a bunch. We do have a couple questions in the chat, which I will read out loud and we'll get through them. A reminder to our audience, we want you to be a part of this conversation. So if you do have any questions, please put them into the chat function or the Q&A feature. I see somebody with their hand raised. Please just drop it either into the chat or Q&A feature, and then we'll get to it. The first question was, what are your thoughts on the Gallery blood test and the full body MRI?
Sure. So these are very common questions. So as I mentioned, we work with the Gallery test. The reason we work with the Gallery test is really primarily for research where we can purchase it and study it and do independent research. We were involved in the Pathfinder studies, which is part of what helped them study their test in patients. It is clinically approved, but not yet FDA approved. And so they're in the process of seeking FDA approval. So it's not an approved screening test at this point. So much of what we do in terms of Gallery test is focus on research. There is whole body imaging that one can purchase as well. For example, there's a company, Pernuvo, that offers that. And, there are benefits and risks to this type of screening. Anytime you do any type of imaging, you may find things we call incidentalomas. And so it's important to be able to work those up and make sure that if someone is ordering a test like that on you, they have the ability to offer you the resources that are needed to fully adjudicate any abnormal findings. None of these are FDA approved or recommended. And so, I think it's a really exciting area that people want to get into, and that's great. But before we would ever make recommendations, we really want to see the kind of data that we are used to using for recommending screening and for recommending anything to our patients. These are not covered by insurance.
Then two questions kind of going off of that is kind of the frequency. So regarding the Gallery test, if you test negative, would you recommend getting it repeated yearly, or is it a one-time test?
Great question. So they don't have data for the cadence to recommend screening annually versus not. They have some data that they've done retrospectively that would say that it could be done annually. The trials that they've done, though, have been one time only. They have an ongoing study in the UK that is annually for 3 years. That should read out in the coming year. And I think that will provide the type of evidence that would be necessary for us to give a recommendation about frequency of that test.
Thank you. Any thoughts on the Prenuvo whole body MRI?
Yeah, so that's what we just mentioned. That's the MRI that's commercially available. I believe it costs about $2,500. Again, this has not been studied. It does not have FDA approval or screening recommendation. MRI is a relatively sensitive, meaning able to pick up abnormalities. But I think it's important to understand how different MRIs are done. So, an MRI can see certain things. If you just pan scan somebody, you may pick up cysts or lesions that may be benign, and those will need to be biopsied or worked up accordingly. But there are certain cancers that would not be picked up by an MRI. So a colon cancer is best found through colonoscopy, especially, the advantage of colonoscopy is that it visualizes the colon, but it can also find polyps and remove them that are precancerous. And so, the scan has variable sensitivity to pick up abnormalities that may be too small to be seen through MRI. But there can be value, but it is not validated.
How soon after cancer treatment would it make sense to start testing/screening?
Yeah, so if you've had a cancer diagnosis, you should stay on schedule for your regular screening, whether that be for breast cancer, cervical cancer, or colon cancer. If you have a family history of prostate cancer, if you're African American, you should be talking to your doctor about that and doing your screening your primary care doctor and doing it accordingly. If you're interested in doing something like MCED tests, in the study, the window was 3 years and that's the only way it's been studied in cancer patients 3 years out. There is no true guidance around it in terms of when might be too soon. And again, because they're not covered by insurance, unless you're on a clinical trial, then you're paying for it at your own discretion.
Thank you. to call if they want to, if somebody wants to be a part of the Center for Early Detection, how they would contact you. I think you maybe had a slide on
Yeah,
that.
if you want to go back 2 slides, 2 or 3, we can go back and we can just leave that up if people want to. There we go. So there's the telephone number, and if you call in, we have a team that will kind of screen you and assess what your needs might be. And if you're already being followed in survivorship, we work with all the different disease groups. A lot of our patients come in from the genetics and prevention program, so you keep your current teams, and we add as needed to the existing team that you have.
Are the tests going to eventually converge to a single way of evaluating cell division?
Cell division can be really important in terms of identifying cancer. So, a lot of the way in which we've historically treated cancer is by targeting cell division. Some of our oldest chemotherapies really work at different phases of the cell cycle to try and interrupt that. And if cancer cells are rapidly dividing and actively undergoing mitosis, then it's logical to try and target mitosis to preferentially kill cancer cells. The way that a lot of the multi-cancer early detection tests are working is not so much focusing on the cell cycle, but for focusing on pieces of DNA. So doing high throughput sequencing to look for pieces of DNA or also signatures. So there can be things called methylation patterns, how the proteins fold, and trying to detect abnormalities within that.
Looks like we're down to the last few questions. There was another question. I know we talked about the MSED test. Someone was asking if it's available to purchase online and how is it interpreted?
So for patients who are high risk, we do offer it at Dana-Farber. We prefer offering it through a clinical trial, so that patients don't have to pay for it. It is an expensive test, but if a person is already a patient within Dana-Farber and wants to have this testing, we can absolutely see them. We don't want our own patients having to go to the internet to obtain services. The interpretation comes though in the form of a positive, or literally say signal detected or signal not detected. So if a signal not detected, that's an implied negative result. A signal detected is an implied positive result, meaning you need additional workup.
Thank you. And the last question I see is asking if there's any research studies that someone could volunteer to help you with.
Oh, I appreciate that. Thank you. I don't know that we have any right now that need volunteers, but it's a really kind offer and really appreciate it. We really are just truly appreciate all that Dana-Farber patients and families do to support our research. It inspires us to do better work, and really to try and push the boundaries of what we're currently doing. So thank you very much.
Awesome. Well, I just really want to extend my gratitude, Dr. O'Donnell, for that fabulous presentation. It seems like it was, people had a lot of questions, so it was wonderful. As I mentioned earlier, this will be recorded and posted on our Blum YouTube playlist and our Blum Digital Resource Center, and eventually the survivorship website as well. So thank you to everyone that joined us today, and thank you, Dr. O'Donnell, for that great presentation.
Thank you. My pleasure. Thank you all so much.
Take care, everyone.